to the podcast. I am so excited to have you here today with us. So thank you for your time.
My honor.
I've been telling you when we were talking off camera, I was telling you that I've actually learnt so much from you and Jill's amazing membership. So I really do have to thank you for that because, yeah, a lot of what I've learnt has come from you. So thank you.
That's good.
All right, so let's dive into hormones. I think one of the first questions we could ask is why? Why should we care about bioidentical hormones?
Let's start with hormones. These are some of the most powerful biochemicals in our body. And they're the fire within that drives so much of the basics of living and some of the wonderful extras of joy and pleasure and reproduction of living. And the output is the highest at age 20 for women and men, plus or minus a couple of years. And from that moment on, the hormone levels decline and they never stop declining and they approach zero in the late 80s. And since most people are familiar with, let's say, ovarian hormones with reproduction, with menstrual cycles, regular menstrual cycles, ovulation, fertility, pregnancy, and indeed, these are deeply embedded in those processes.
Mm-hmm.
But what a lot of folks are not aware of is these hormones are so powerful and there's receptor sites for them in almost every cell, tissue, and organ in the body. For example, the brain has zillions of estrogen receptor sites. And absent estrogen effect in the brain really loses function and can even head towards dementia.
Yeah.
The arteries, the bones, the muscles, the skin, the hair. Powerful biochemicals do great work everywhere. And, it wasn't so much an issue 100 years ago because the hormones were declining, but there wasn't such a thing as menopause for most women. Most women were off of Earth by midlife, by 50, and most men a little earlier than that. So, but as we expanded the lifespan, now, and we're all maturing and gaining our knowledge and experience and our beneficial effect for many, many years, 50 years beyond this midlife. And I'll tell you, we want these hormones. Oh boy, do we want these hormones.
Mm-hmm.
And you can ask 80% of women who have gone into the perimenopause and menopause what it's like for them. They have life-stopping symptoms. Can't sleep, mood changes, dry vagina, painful intercourse, skin changes, hair changes, libido changes, drive, just daily drive and success, energy changes. Men, likewise. Ask a man who's midlife and he's losing his erection how that is for him.
Yeah,
It's a
absolutely.
big deal
Mm-hmm.
because without these hormones, we lose so much.
Yeah.
Well, this has been known for thousands of years. And the earliest record we have was from the Chinese who learned how to replenish these hormones. And what they did is they collected the urine of young, healthy women and young, healthy men separately, dried it out, and fed it to the aristocracy, who were doing a lot better than the non aristocracy.
How they found that out, I do wonder.
Because the urine actually contains hormones.
Yeah.
And so this has been going on for a long time. And in the 1940s, the 50s, it just exploded in the United States when pharmaceutical manufacturers extracted urine from pregnant mares. And although their hormone configuration is different, it's good enough to have made a major difference for by 2000, there was 18 million American women in menopause on hormones. That's 40% of American women in menopause.
Right.
So it's been going on for a long time for very highly motivated reasons, because when I talk to a lot of people in their 20s, this makes no sense to them at all, hormones. But you talk to a woman or a man who's 50,
Mm-hmm.
and there's a tremendous interest in it because they want to have their power back. They want to have their sexuality back. There's things that they don't know about. They really want their bones, their muscles, and their heart and their arteries.
Mhm.
So replenishing hormones for everybody
Yeah,
is a
absolutely.
fabulous idea.
Yeah, 100%. Thank you for that. That makes complete sense. Yeah. And to your point, there's invisible benefits, right? So, whilst we want to be sleeping well and don't want to be anxious or depressed, and we want to be able to make love with our partners and all these wonderful things, there's all those invisible benefits that people don't realize these hormones give us. They protect us for the decades to come from preventing, hopefully, a piece of the puzzle of preventing dementia, heart disease, osteoporosis, right? To your point, there's a lot of invisible benefits we need to tell women about, and men.
I think you're bringing up one of the most significant issues of all.
Hmm.
And being a general physician, I was treating people at all ages. And right away in medical school, a gerontologist, a specialist in aging, was lecturing to our senior medical school class and said, "You guys know thousands of diagnoses. Let me tell you what's really happening to the elderly.
Right.
They're losing their muscles through a process called sarcopenia. They're losing their bones through a process called osteoporosis, and they're losing their cognitive ability and going towards dementia." And this is how they wind up in assisted living facilities and nursing homes. You want to do something for the elderly? Prevent these.
Yeah.
Well, as someone on our medical board spent her early career working for nursing homes. She's a medical doctor. And I asked her once, what percentage of women in nursing homes are there because of hormones? She said 80%,
Yeah. Wow. Yeah.
just from hormone loss,
Yeah.
because you need the hormones for the muscles. You lose the muscles, you move from cane, walker, wheelchair, and you move into adult diapers for
Yeah.
muscular reason and bladder reasons and vagina reasons.
Yeah. Yeah.
So
Absolutely.
it's the long thing. People meet up with it in midlife,
Hmm.
and there's plenty of symptoms that need alleviation, restoration of sleep,
Yeah.
for example.
Hmm.
But what they don't see is what they're preventing.
Yeah.
And there's a moment in many people's lives where they realize they can't be taken care of at home anymore.
Yeah.
And they need to make that transition. And bless nursing homes and assisted living facilities, but they don't want to make that transition, most of them. They want to stay at home.
Yeah.
So the very best thing you can do for the
Mhm.
short term and the long term, as you mentioned, Tara, is replenish those hormones.
Yeah. 100%. Okay. So then here's the question that's on everyone's mind. Why then are people still so scared of hormones, including a lot of doctors, even?
Well, it's misinformation, and this is one of my favorite topics to address because I've never seen anything like this in my whole career, where some piece of misinformation came along and scared people away from something that is so critical for them.
Yeah.
And you're talking about hormones were in widespread. 40% of women in America were on hormones.
Yeah.
And then out comes this false reporting of a poorly designed study called the Women's Health Initiative, and they didn't really claim it, but the press claimed that there was an increased risk of breast cancer for women treated with hormones. Well, that wasn't what was in the study.
Yeah.
That's the phenomenal thing.
Hmm.
What was actually in the study was women who were on Premarin, horse urine derived estrogen, had a lessened risk for breast cancer. It's right there in the
How could
study.
Right? And so women listening are going to be like, well, how could they get that so wrong? If the opposite was true, it's actually good for us and preventative of breast cancer. How could we get it so wrong?
Well, they got it wrong because of a glitch. There was two arms of that study: Premarin alone and Premarin combined with a very iffy molecule called a progestin. It's in the birth control pill. It's in some IUDs. And what it stated in the study was there was a slight but statistically insignificant increased risk for breast cancer with Prem Pro. Well, everyone in science and medicine knows what statistically insignificant means. It means don't draw any conclusions.
Yeah.
But the press just saw and grabbed the words and exploded it out for some crazy misogynistic
Hmm.
energy that exists on this planet that has baffled us all forever.
Yes, and recent times very much. Hmm.
Mm. And
Yeah.
18 million women who are on hormones dropped to less than 2 million almost overnight. And it scared women and it scared physicians
Yeah.
because all they heard was the same thing right out of the press.
Crazy
Well,
though.
what we knew by 2006 is that slight statistical insignificance dropped to zero. We knew that was being followed. And by 2017, the original study committee who published in the original journal that they had published the initial study in, that they made this statement: after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke.
Mm.
But like you're pointing out, millions of people worldwide, including healthcare providers, got scared. Very, very few people have learned thus far about the retraction.
Yeah.
Now, there is a lot of energy going into the retraction.
Yeah. Yeah.
And what I'd like to do for your audience is I want to give you the best science.
Yes,
And I can do it
please.
in a brief period of time.
Perfect. Love it.
But
So just to make a point clear for everybody, the the issue that wasn't really the issue was the progestin, right? Is that clear? It's like
well, I like how you said that wasn't really the issue
yeah,
because it turned out to not be an issue.
yeah, because it was statistically
Even with
insignificant.
Provera, there was not an increased risk.
Yeah.
It wasn't there in the first place because it was statistically insignificant.
Insignificant. Yeah. But it's crazy how this information gets run with. And again, yes, perhaps this is the issue that we see time and time again with the media, right?
Yeah.
They make problems for everybody. But running with this misinformation, and the issue is once something is, I don't know, slandered, it's very hard to come back from that, right? Even if it was completely incorrect, it's very, very hard to try to correct that once it's out there. So a huge disservice for women, that Women's
Absolutely.
Health Initiative. Yeah, awful.
But I would like to clarify the science for
Yes,
your audience.
please.
And it begins with this: that we're human beings, we're at risk for thousands of medical diagnoses and hundreds of cancers.
Mhm.
And for example, males are at increased risk, relatively speaking, for prostate cancer over other cancers.
Yeah,
Wasn't always the case. And when I was in medical school, this was not so.
right.
Modern things have increased the risk for prostate cancer.
Okay.
And women are at increased relative risk for breast cancer.
Mhm.
Wasn't so when I was in medical school, now is.
Wow.
Given we're all at risk for all kinds of stuff, here's the actual science on that risk. Women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who are not treated with hormones. And I want to take it one step further. Women who have had breast cancer and had that breast cancer treated have an increased relative risk of recurrence
Mhm.
as opposed to a woman who's never had breast cancer getting breast cancer.
Yep.
Given that increased risk, if she's had that breast cancer properly treated, she's at less risk for recurrence if she's treated with hormones than if she's not.
Mhm. Big news.
That's the actual science. Less risk, hormones, very similar thing is true for men as well.
Yeah. So that answers a question that I was going to ask for women because there's so many women who have had breast cancer or who have breast cancer in their family and they're very nervous about these hormones. But when you look at the science, these hormones reduce the risk.
Well, I'd like to address that for a minute.
Yeah.
For one thing, you're offering to your audience a free PDF copy of my book,
Yeah.
Happy Healthy Hormones. In chapter 3, I go into this in more detail.
Mhm.
And then there's a Bible out there on this. An
Mhm.
oncologist who specialized in breast cancer, Avram Blooming,
Yeah.
and his writing partner, Carol Tavris, have a book called Estrogen Matters.
Mhm.
They're very wrong, and we're in dispute about their comments about compounding pharmacists,
Yeah.
but they're exquisitely accurate and scientific about the evidence to back up what I just said,
Yeah.
that women who are treated with hormones are at less risk.
Mm-hmm.
Women who've had breast cancer and had it properly treated are at less risk. if
Yeah.
they're treated with hormones than if they're not.
Mm-hmm.
And that's irrespective of receptor sites. People don't understand receptor sites well.
Mm-hmm.
Many doctors don't understand receptor sites well.
Mm-hmm.
That even women with positive receptor sites,
Yeah.
that doesn't matter. The science stands that women with positive receptor sites, negative receptor sites, women who have had breast cancer, had it properly treated,
Yeah.
are at less risk for recurrence if they're treated with hormones.
Yeah. Right.
And if you want a little more clarity about the receptor sites, normal breast tissue, every one of those breast glandular cells has a host of receptor sites,
Mm-hmm.
estrogen and progesterone. That's
Yeah.
healthy.
Yeah.
But any given breast tumor, which a cancer ultimately is,
Mm-hmm.
has all kinds of cells in there. It's got native cells, well differentiated cells. They look like and they behave like breast glandular cells. And they've got cells that under the microscope, you can't even tell they're from the breast. And
Right.
biologically, they don't function and they don't have receptor sites.
Yeah.
That's the part of the tumor that's the trouble.
Yeah. Yeah.
That doesn't respond to hormones at all.
Yeah.
So
Yeah.
people got to really open their mind about the scare that women are given. Well, I had an estrogen positive receptor site. Well, you
Mm-hmm.
had a well differentiated cancer.
Yeah.
So you still fall under the situation of, if you've had breast cancer and you've had it properly treated, you're at less risk for recurrence if you're treated with hormones.
Yeah. Yeah.
Doesn't mean we're risk free.
Mm-hmm.
Cancer has causes, they're not hormones. Cancer
Yeah.
has a lot of causes.
Yeah. Exactly. Yeah.
They need to be addressed.
Yeah.
But
Absolutely.
hormones.
It's not hormones. Yeah, cancer is multifactorial. Absolutely. Um, okay, so many things that I could ask, but I think why don't we talk about? I guess I want to ask you, when is the best time to start on hormones, in your opinion? And wrapped up into all of that is because there's so many women in my community who are still scared to start on them, or they're scared to start on them too early, or they think, if I don't need them yet, it's best not to go on them. I'm kind of coming into the thinking of, well, why should we wait? And I don't know what your thinking is, but why should we wait until we are really symptomatic? Right? We can't remember things anymore. We can't sleep anymore. We're achy, et cetera, to start hormones. Is there room for preempting the decline, which to your point starts in our 20s? Should we be preempting this a little bit? Do we have to wait for symptoms? And what about testing? So there's a lot in that.
Well, absolutely. In medicine, an ounce of prevention is worth 82 tons of cure.
Yeah.
The earlier, the better. And then again, for so many of us, we don't seem to move until something shakes us up a little bit.
Yeah, sad truth. Hmm.
So we accept a treatment of women and men at any age.
Hmm.
And we've had women start in their 80s. And do I wish that I'd been able to start in their 40s? Oh, yeah. It's harder to recover stuff. You can recover stuff, but it's harder when you're dealing with it long-term deficits. So let's go practical from a physician's point of view. When do women call our office? For the most part, they've had some disruption in their sleep, in their mood, in their menstrual cycles, in their libido, in their vaginal health. There's usually something strong enough to go, what's going on here?
Yeah.
Which to me is the purpose of symptoms.
Yeah.
It's our own being giving us a wake up call. It wants us to answer a question.
Hmm.
The question is, what's going on here? The issue is it wants the right answer.
Yeah.
And it's strong enough to drive us from 80% of women to professionals' offices, and that's great.
Hmm.
So the majority of patients that I've seen over the years, they're coming in when the periods have stopped and they've got these life disruptive, sleep disruptive, mood disruptive symptoms. That's a great time.
Yeah.
I could say categorically, bottom line, if you haven't come into the study of this prior to your last periods, when your period stops, come in then.
Yeah.
When that period stops, your hormone levels have dropped majorly, and you are experiencing bone loss and vaginal loss and cognitive loss. So, as a hard stop, come in when your periods haven't been around for a while.
Yes.
Now we can do a lot better than that.
Hmm.
A lot better than that because prior to the period stopping abruptly, and that means that those hormone levels have really dropped from here to here.
Yeah.
No period, you've got major droppage. But prior to that, there's a period called the perimenopause. And you could date the onset of the perimenopause where things are not quite what they used to be.
Mm-hmm.
Some period irregularity. Once that period gets irregular, it's very unlikely that the woman's ovulating.
Yeah.
And if she's not ovulating, her progesterone, which is so prevalent in a young woman, has dropped majorly.
Yeah.
So when those periods get irregular, that could be a real signal
Yeah.
to now seek out the help.
Yeah.
And there's often symptoms with that loss of progesterone, big time.
Mm-hmm.
But then, as you were hinting at or said outright, there's a place even before that that would be the ideal time. You got a young woman, she's still ovulating, but what happens on this planet is if this is estrogen and this is progesterone, they both don't decline perfectly at the same time. The progesterone can fall earlier and deeper than the estrogen. That means there's an imbalance there. Women who are getting breast tenderness,
Mm-hmm.
women are getting anxiety. What a strange word. Yes, life is challenging, but there's many women who report anxiety. Where'd that come from? I didn't have anxiety. Yes, I was very successful in my life, managing a lot of stuff, but now I got this thing, anxiety. It's
Yeah.
because the great calmer,
Yeah.
progesterone, has dropped lower than the estrogen. She still could be ovulating. So I'm backing us up be, because it's better to start then.
Yeah.
Now, how strong is the motivation? Your cramps return, PMS returns, your flow's heavier, you're a little irregular. That could be the signal. And this could happen in your 40s or even your late 30s.
Yeah.
Getting a
Absolutely.
little vaginal dryness. Never had to use lubrication in penetrative intercourse.
Yeah.
Now you got to use lubrication. A major change has taken place in the vagina from droppage of estrogen.
Yeah.
The moment you switch from no need for lubrication to lubrication, that's a great time.
Yeah. Yeah.
So I'm backing us up.
Yeah.
And then, you know, even before that, there's a lot of young women for a variety of reasons that they're working with the challenges of life, but they've developed this thing called anxiety. I mentioned this before.
Mm-hmm.
And they're good people,
Yeah.
strong, leading good lives.
Yeah.
There's this new element that is actually anxiety. You don't reach out. It is not a Prozac deficiency. It's an estrogen deficiency,
And
and it's a
progesterone.
progesterone
Yeah.
deficiency. Excuse me.
Yeah.
Thanks for the correction. You're so right. It's that progesterone that's dropped. The great calmer.
Yeah.
What happens when you lose the great calmer? You get uncalm. And, and that's called anxiety or whatever
Anxiety.
else you want to call it. Or it's called I'm not sleeping as well.
That's it. Yep. Mm-hmm.
So, there's many young women, and we're seeing more and more of them that are picking up on this in the 20s.
Yeah.
And just a little over-the-counter progesterone can make such a difference.
Absolutely.
You
Yeah.
wish it wasn't so. You wish life was so well structured that we didn't have these declines or they weren't so dramatic, but there's natural remedies for it.
Yeah.
There's
Absolutely.
natural, so I'd say in the 20s is if you're not regularly menstruating, if you're getting anxiety that you didn't have, if you're
Yeah.
not sleeping as well, if your period's a little regular, ideally you would find a provider who really understands this work.
Yeah, absolutely. And I want to talk about your providers and what you offer. I just wanted, so basically, you're saying if you're in your 20s, let's say somebody has endometriosis, and they're in their 20s and they have symptoms of low progesterone, is it safe to start taking natural progesterone even in your 20s?
Absolutely, it is. The endometriosis issue is another issue,
Mhm.
but it is safe. And if you're skilled, you're not trying to replace your own progesterone. You're just trying to augment it and bring it up to a more reasonable, healthy level.
Yeah.
Why wouldn't it be at a reasonable or healthy level?
Mm-hmm. Mm-hmm.
Because there's this thing called fight or flight. It's a biological response to protect us from saber-toothed tigers
Mm-hmm.
leaping out behind a tree,
Yeah.
and we need to fight or flee. Better flee.
Mm-hmm.
And there's an amazing biological response to empower that. And it's led by hormones. Well, people are most familiar with it being led by adrenaline and cortisol.
Mm-hmm.
They're the main rocket fuel. But what people often don't realize, other hormones that are powerful are recruited. So estrogen and testosterone are recruited royally for this.
Yeah, right.
And the best example of this is young women Olympic athletes. There's a lot of those women that are not menstruating.
Yep.
Their training programs are so over rigorous,
Yep.
they're so stressed by it that they're recruiting their female hormones for the training process, and they're not menstruating.
Yeah.
Not going down the female pathway, it's being recruited for the stress pathway.
Mm-hmm.
That's how these hormones get low,
Yeah. Good
is
point.
there's biological reasons related to fight or flight. So best case is for all of us that we acquire information and tools and support to work with our emotions, our mind, our consciousness, our life, so we're leaving relatively relaxed, happy, rich lives.
Yeah.
That's the antidote. That's the medicine. That
Yeah.
doesn't trigger the biology, the stress response. And we get so awake and enlightened that we accept so much more than we do right now.
Yes.
That's the key to it. It's
That is the key.
really
Mm-hmm.
respecting the stress response, respecting the anxiety, the depression,
Mm-hmm.
realize I must acquire some skills so I can get skillful at this so my life improves. This
Yeah.
is what one of the main tasks.
Absolutely. It is.
And in the interim, if you're committed to that, if you're committed to healing,
Yeah.
taking a little dab of progesterone every day, it really works.
Yeah.
If you're not committed to healing,
Yeah.
your being is not going to allow you to get away with some nice relief from
Yeah.
something, or it'll be short acting. It'll be like
Right.
whack-a-mole.
That's
Okay,
right.
you address the anxiety with Xanax.
Yeah.
Yeah, well, that works for a very short time. It's very addictive stuff, and it
Yeah.
doesn't address. Okay, progesterone. I use progesterone.
Yeah.
Well, that is so much better, so much kinder, so much safer. And you're just replenishing deficits, shortfalls.
Yeah.
But
Yeah.
again, you don't want to rely on that. You want to go after the causes.
Yeah, absolutely. It's multifactorial, and the
Yeah.
hormones are wonderful, needed, should be addressed and used, but they're just a tool in the toolbox at the end of the day. Yeah. I just want to ask about your thoughts on, and I want to get to testing, but so many women, and there's a lot of chatter out there, right? We know there's a lot of chatter. There's a lot of amazing hormone doctors who have a lot of different viewpoints. What are your thoughts on cycling progesterone in particular? Because that's usually the first hormone that women start on. And so, what are your thoughts on when does a woman need to cycle? Do they need to cycle? At what point should they not cycle? Yeah.
Well, behind all of that talk of cycling is understanding the menstrual cycle and the hormone patterns that are occurring during a healthy menstrual cycle. And I'll draw it on the screen here. If this is day 1 of your period and this is day 28 of your period, let's track estrogen levels.
Yeah.
They rise until day 12 and then they drop quite a bit when you ovulate. And then they rise again to almost the same level and then they go down, and that's when you have your next period.
Yeah.
That's estrogen. Progesterone behaves very differently. It's relatively low, and only if you ovulate,
Mm-hmm.
it goes really high.
Yeah.
In fact, it looks different than I did. It actually starts fairly high,
Mm-hmm.
and if you don't ovulate, it stays there.
Yeah.
If you do ovulate, it shoots off the chart because there's 100 times more progesterone than there is estrogen. And
Mhm.
when you refer to cycling, wouldn't common sense say that you would take if you're not raising that progesterone, for example, if it's flatlining because you didn't ovulate, wouldn't you want to take the progesterone during the second half of the cycle and
Mhm.
not earlier?
Mhm.
Well, here's where a major principle of hormonal treatment and medical treatment comes in. It's called individualization.
Mhm.
It
Yep.
varies woman to woman.
Mhm.
So I was aware of those menstrual curves.
Yeah.
And when I identified a woman that wasn't ovulating, I would suggest to her, why don't you take the progesterone on days 12 to 28? That's what your body did.
Mhm.
And you don't have to be concerned about the first. So, woman after woman early on in my career would come back and say, boy, when I take that progesterone on days 12 to 28, I really feel myself. This is great stuff. Is there any reason why I couldn't take it earlier? And what did I know? I knew what the natural thing was, but you never know. I said, well, why don't you try it?
Yep.
And the woman after woman after woman would come back to me and say, well, I already have, and I love it. I like to start on day 7,
I
or I'd
love
like to
that. I already
start
have.
on day 3.
Yeah.
And it works great,
Yeah.
Doc. And then it took me a while to figure out that days 14 to 28 wasn't enough for me. I needed to start it earlier.
Yeah.
So it's an individual thing.
Yeah.
And it's one of the things we really encourage in the book
Yeah.
is there's the general information, and then there's a certain amount that these hormones are going into your body. Once you understand a few things about them, you don't have to go to medical school,
Mhm.
and you get a feel for them, you'll figure it out what's
Yeah.
best for you.
Yeah.
So cycling is a great idea. We used to at one point in my career, I love math and I love spreadsheets, and I
Mhm.
thought, why don't I replicate in a menopausal woman those menstrual curves?
Mhm.
And I would give every woman in my practice a spreadsheet, and it would say how much biased, how much progesterone to take every day, and it varied day to day.
Oh.
And it was, I've been very fortunate. I've had a demographic of women are like yourself.
Yeah.
They're interested, they're
Yep.
proactive. So a lot of my patients really embraced it. They thought, hey,
Sure.
this makes
Yep.
sense. This copying nature.
Yeah.
So I did this for a full year. I took all my patients off the regular daily dosages
Mhm.
and gave them a chart and how much to take.
Yep.
And on my yearly follow-up, this happened with every single woman.
Mhm.
I said, well, how'd that go for you? And they said, well, it was okay, but I went back to taking it daily because I felt so much better. And you start realizing that you got theories,
Yeah.
but in menopause, it's not the same as a
Yeah.
young woman. So
Yeah.
I love the idea of cycling, but each individual woman who's in the perimenopause,
Yeah.
it's you can figure it out yourself and it's not hard. And then
Yeah.
you get an internal feel for these hormones
Yes.
and you can make adjustments on your own, which we highly encourage.
I love that you encourage that. I think that's so important. I think so many people give up their thinking to their doctors. And whilst obviously doctors are, you're obviously very well trained and have a lot of clinical experience, it's very important, though, to have a collaborative approach, I think. And as a woman in particular, to really be able to, like you said, know your symptoms, understand how you're feeling, and know that a little bit more, a little bit less of that hormone isn't going to hurt you. And I think a lot of women are very scared about overdosing these hormones, but that's very tricky to do, right?
It is. These hormones are so powerful that most, but not all, a woman takes too much estrogen. It overstimulates her breast glandular tissue. She gets breast tenderness, breast fullness, breast pain,
Yeah,
nipple tenderness.
yeah,
She's not going to go there. And
yeah,
if she goes there, she's going to back down.
yeah, yeah,
You take too much progesterone at night,
yeah,
you get too calm. And you wake up the next morning like you took an overdose of a sleeping pill. You're
yeah,
groggy. You go, what did I do here?
yeah,
It's these
exactly.
built-in protections. You take too much testosterone,
Mm-hmm.
oily
Hmm.
skin, pimples,
Yeah,
hair on your mustache. You don't
yeah,
do this. You get
yeah,
overly aggressive. The hormones are so powerful that there are symptoms of overdose. In fact, we list those in the book.
Yeah.
And every woman that we work with, they get a card which lists the
Right.
symptoms of too little and too much.
Very helpful.
And there are exceptions.
Mm-hmm.
There are some women that can take super physiologic doses
Mm-hmm.
and they feel great and they don't feel bad.
Yes. Yep.
But this is the wrong way to proceed. We've learned many harsh lessons from taking more than our bodies were designed to do. They work for the short run for a very small number of people, by the way,
Sure.
but they have long-term consequences.
Yeah.
And so in our method, how we train physicians and nurse practitioners
Yeah.
is we know the numbers.
Yeah.
We teach them of the parameters. We've designed the hormones to where it's very hard to overdose
Wow.
because we just are very specific.
Mm-hmm.
But there is a wide range.
Yeah.
I mean, we know the numbers that the average amount of estrogen, for example, strength, we use biased. You got to do some math to calculate the strength. But if you just to give you a number, it's 2.8 milligrams of estradiol equivalent. That's the average.
Mm-hmm.
The range, so that we can include all women and
Mm-hmm.
get them in good levels, runs from 0.9 to 4.8.
Oh, okay. Wow. 4.8.
That's 5 times
Mm-hmm.
that lower number there.
Yeah.
That's the range.
Yeah.
There's no problem with that.
Sure.
We go through a process of starting low and gradually increasing and alleviate symptoms.
Yeah.
But this is one of the reasons that women, we need to partner with you
Yeah.
because you're feeling it.
Exactly.
And there's such a wide range. So what does it call for? Individualization. So individualization is not hard. It's easy.
Yeah, exactly. And I think people are going to have a lot of questions around testing, right? So, talking about all this, they're probably going to be thinking, well, do I test? When do I test? How do I test? So, what are your thoughts around testing, real quick? And then maybe we'll touch on biased and why you use biased. And then we can touch on about the menopause method and what you have to offer there. So, testing, do we test in perimenopause? If we don't test in perimenopause, do we test in menopause once we're on the hormones? How do we test? What are your thoughts on that?
I have very, very strong opinions on this.
Yep, I know.
For one thing, it's perilous and money wasting
Mhm.
to test a woman's hormone levels in the perimenopause. At the very time you're undergoing symptoms and you're wondering if your hormones are going wacky, it's the wrong time to test.
Yeah.
And for one thing, you don't need to. Perimenopausal symptoms are so strong and
Mhm.
so clear
Yeah.
that if a woman finds a provider who's specializing in treating women in perimenopause and menopause, you're identified in a flash.
Yeah. Oh, yeah.
And one of the things that we do in our book is I list those symptoms.
Yeah.
And then here's what happens in the perimenopause. I drew out these wonderful estrogen curves, for example.
Mhm.
So classic. It's in every textbook.
Yep.
But in the perimenopause, the estrogen level, for example, is lower. The ovaries can't put out as much.
Yeah.
They don't have the power.
Yep.
So the brain in the pituitary realizes this and goes, wait a minute, we need more estrogen. So it pumps out a stimulating hormone to signal the ovary to increase that estrogen. And it works temporarily.
Yeah.
You get that output of that stimulating hormone, you get an output from the ovary. But what it looks like medically is you're running low, you get the punch, you
Yep.
run high, but you can't keep it up. So you run low. And so you're like this. So I learned this the hard way.
Yeah.
You got very erratic levels, higher than you've ever been and lower than you've ever been. But in general, you're lower.
Yeah.
When you add up how much hormone you put out every month, it's lower.
That's a very important point. Very important point because a lot of women, they confuse and they hear all this talk online about estrogen dominance and they get very confused and also very scared. I saw this last week. A client had a Dutch hormone test and she had a blood test and she's only in her early 40s and she's definitely in perimenopause, but she had two very, very high readings of estrogen. So her fear was, I have high estrogen. But I think that's a very important point you just made. You're going to get that scream from the brain. Your estrogen's going to go up. If you happen to test on a day where the estrogen's high, that doesn't mean you have high estrogen because it's going to come down and it's going to be on average lower than you've ever had before, even if you get these high peaks. Very important.
That's precisely why you're getting the symptoms,
Yeah.
because it's been lower than it ever has been in your adult life.
Yeah.
I learned this the hard way. I tested a woman who was in the perimenopause
Hmm.
because I was interested in testing
Yeah.
very early on in my career. She's having hot flashes. She's waking up in the middle of the night. She's drenching her pajamas.
Yeah.
She stays awake for a couple hours. She's having hot flashes during the day. I know for certain she's low in estrogen,
Yeah.
but I test her, and the estrogen levels come in high. And I say to her while she's looking at her beautiful report,
Yes.
I'm saying to her, now I want to treat you with some estrogen. And she looked at high.
Yeah. Yeah.
And I said, but I know you're low overall. And she
Yeah.
looked like I was nuts.
Yeah. Hmm. I've come
She's going
across
to
this.
a doctor's.
Yeah.
I got high levels and he wants to treat me with that.
Yeah. Yeah.
So there's no need ever to test a woman's hormone levels in the perimenopause. In fact, it's perilous. You could make the error that you and I have been
Correct.
emphasizing here.
Very
The
confusing.
symptoms will tell you.
Yeah. Absolutely.
And then in the early menopause,
Uh-huh.
I also tested women in the early menopause until they haven't had a period for 6 months, and they want an initial test, and I want an initial test,
Yeah.
and they get to spend $340 for the 24-hour urine,
Know what
and
you're
I
going to
get to
say.
say to them,
Yeah.
your hormone levels are low.
Makes sense.
Yeah, no period.
Yeah.
So I'm 100% committed to testing 100% of the women we work with.
Yeah.
We use only the 24-hour urine hormone test.
Hmm.
There are so many problems scientifically with the paper 5-spot urines,
Hmm. Yeah.
with the saliva.
Yeah.
I'll give you my best shot, and I'm very strongly opinionated. And one thing that our group does is we've run comparative testing.
Yeah.
That means we took two women who were being treated
Yeah.
and two men who were being treated,
Hmm.
and we split their specimens to four different labs on the same day
Right.
and two different blood labs.
Mm.
And there was major discrepancies all over the
Sure.
place.
Yeah.
And there's scientific reasons for it. But the main thing is we test 100% of women. They come to us, they have symptoms. We start on low doses,
Yeah.
estrogen bias, progesterone, testosterone,
Yeah.
and the women feel better.
Yeah.
And the day the woman says to me, oh my God, I think I've got this figured out.
Yeah.
We teamed it and I figured out my individual doses.
Hmm.
And I say, okay, great, now we're going to test you.
Yeah.
And we did a study on this. What we learned when a woman said that, 50% of them were on estrogen levels too low to protect their brain and vagina over the long haul.
Wow.
50%.
Yeah.
And 25% on them were on estrogen doses too rich that put them at risk for breast glandular cell proliferation. We don't want that.
Right.
Only 25% of them were in the optimal zone. We know what those numbers are. But by the time a woman's saying, I feel so much better, she's really close. The
Yeah.
purpose of that 24-hour test is either to confirm she's nailed it, see you next year,
Yeah.
or she's a little bit off.
Yeah.
So when we do that 24-hour urine hormone test, at a time when a woman says, I've got this,
Mhm.
and most we do some tweaks, and we don't never have to make tweaks so big that we want to test again. Doesn't
Sure.
happen. They're so close.
Yeah. Yeah. Excellent. I love it. I love it. Let's touch real quick before we say goodbye on estradiol versus biased. Why do you use biased?
Well, biased is a combination of two of the three major hormonally active estrogens. Estrogen is really a family of hormones. And estradiol is the strongest hormone put out by the ovary.
Mhm.
And another estrogen is called estrone. It's about 80% as strong as the estradiol. And there's a third hormone called estriol, and it's about 1/8 the strength of estradiol.
Mhm.
And here's what we know about young women every single month. They put out more estriol than they do the sum of the other two estrogens.
Yeah.
This was first uncovered by a breast cancer oncologist specializing at the University of Nebraska in the 1960s using 24-hour urine hormone test. He wanted to see if there was a difference in the urine of women who were young and healthy
Yeah.
versus women who had breast cancer. What he learned was the average amount of women had 1.3 times as much estriol
Yeah.
as they had the sum of their estrone and estradiol.
Yeah, wow.
And one of my beloved mentors and friends and teaching colleagues, Jonathan Wright, he in the 80s, he said, when he discovered Dr. Lemon's work, he said, why don't we just copy nature? Didn't have a reason other than
Makes sense.
do what nature does. And he invented biased and triast
Right.
and just replicated those ratios.
Yeah.
What Dr. Lemon found, that's the oncologist, is the woman that had breast cancer had less estriol.
Mm-hmm.
I happened to be funded to repeat that study on young women in 2013.
Right.
And what I found on the average, there was a range, young healthy women, and we heavily scrutinized for young healthy women, regularly menstruating, normal BMI, never
Yeah.
been pregnant, no hormonal birth control.
Yeah.
We learned that they had 1.1 times on the average amount of estriol than they had the sum of estrone and estradiol. So I'm like, duh, let's copy nature.
Yeah. Yeah.
Now, the interesting thing is when Dr. Lemon and Dr. Wright proposed this in the 1990s, along comes the discovery of the estrogen receptor sites. And we learned that there was two types, receptor site alpha and receptor site beta. And receptor site alpha was most active during the first 14 days of a cycle. And it was stimulated primarily by estradiol. And it's a proliferative
Yeah.
phase. The uterine lining develops that eventually would receive a fertilized egg. But the great mystery to me with this original design is every single month a young woman is preparing for breastfeeding.
Yeah.
So not only is the uterine lining proliferating, but brand new breast glandular cells are forming in preparation for possible lactation right there in each individual cycle.
Yeah.
And this too is under the influence of estrogen receptor site alpha, primarily stimulated by estradiol. And if she gets pregnant, that's what a road traveled. If she does not impregnate, a whole deproliferative phase begins, where finally the uterine lining deproliferates so much it sheds,
Yeah.
and the breast glandular cells disappear by a process called apoptosis. So beautifully named, apoptosis.
Yeah.
And women feel this. Many women feel this. They feel that their breasts get fuller as their cycle's progressing, and if they don't get pregnant, their breasts reduce to a lesser size.
Yeah.
That second half, that deproliferation phase, is under the influence of estrogen receptor site beta, and the principal stimulant of estrogen receptor site beta is estriol. We learned this long after Dr. Wright proposed bias.
Yeah.
Over 15 years after he proposed it,
Yeah.
we learned about these receptor sites. So I love deproliferation.
Yes.
Proliferation in a midlife woman, breast glandular cells not needed, and there's mitosis there, and that's a very vulnerable time, cell division. Mistakes can be made there. So breast cancer prevention is the bottom line in hormonal medicine.
Sure.
Hormones do not cause cancer, breast cancer,
Yeah.
but breast health is the bottom line, and we want that deproliferation.
Yeah.
So our formulations can start with 80% estriol
Yeah.
and 20% estradiol bias.
Yep.
Sometimes we change that ratio when the test results on the 24-hour urine gives us the data that, okay, a little alteration is needed here. But I love estriol.
Yeah.
And it's so good for the brain, and it's so good for the vagina. It is
Yeah.
because it's all over the body.
Yeah.
So
Okay, amazing. Excellent explanation. Okay, so let's now talk about you have a education facility, I suppose, for want of a better term, the menopause method, right? So talk a little bit about that, because women who are listening, they're gonna want to know how they can find somebody like you. So you train physicians up in your method, right?
That's the main thing I do.
Yeah, yeah. And
I
that's the
train and
menopause
I
method.
train and mentor them.
Yep.
So we have
Fantastic.
an online 12-hour training class for treating women,
Yep.
and then additional Monday morning 2.5 hours where they detail every step of the way. We've got extensive software, the apps that communicate with portals. I've
Mm-hmm.
got an amazing team,
Yep.
a beloved team,
Yep.
and we've really gone from A to Z how to make this standard of care.
Yeah. Yeah.
And we train them and we mentor them. I do weekly grand rounds with the professional.
Yep.
That means 1 hour every Wednesday.
Mm-hmm.
We have a beginners, which is in the morning, and advanced grand rounds in the afternoon.
Yep.
Physicians and nurse practitioners who are trained in our method bring
Yep.
their questions, bring their tough cases.
Mm-hmm.
It's how medical school and residencies are designed. No need to
Yep.
reinvent that wheel. So
Yep.
we train them. And another aspect that I think is worth mentioning is for women, the optimal way, and for men, the optimal way to take these hormones. How do you take them?
Yep.
Pellets, injections,
Mm-hmm.
pills?
Mm-hmm.
No, no, and no. You want to inject yourself daily with hormones?
No,
No.
thanks.
Pellets, big problem for I know some people know how to do the pellets, but it's so hard to individualize it. And I
Yeah.
take a stand. I do not recommend pellets.
Yeah. Yeah.
And oral hormones, no, they're fraught with difficulties. I won't go into it right now. The optimal way for a woman to take her bias, her
Mhm.
progesterone, and her testosterone and DHEA
Yeah.
is applying it to your skin.
Yeah.
And this has been done with hormones since the early 80s
Yeah.
by compounding pharmacists.
Yeah. Yeah.
These are the pharmacists that are really most interested in stuff. They
Yeah.
love mixing things. They love making up individual
Yeah.
prescriptions.
Yeah.
And what they put the hormones in is a carrier.
Mm-hmm.
So back in the day, my patients used to receive a white cosmetic jar,
Mm-hmm.
and inside the jar was hormones,
Mm-hmm.
plus what the hormones are carried in.
Yeah.
One thing about ovarian hormones is they're very poorly soluble. You
Mm-hmm.
cannot get them into solution with water. You need strong solvents
Yeah.
to get them into solution. So when you dip your spoon in there, you're pulling out the same dose every day. Or
Yeah.
using a pump or a copy click, the same dose comes in because they're in solution.
Yeah.
Well, 10 years into treating women, I had never seen a hormone. My pharmacist was shipping my prescriptions directly to the patients.
Yeah.
And they misshipped a woman's bias to my office. I had never seen a hormone. A white cosmetic jar sealed. I was fascinating. I broke the seal, opened the top, and out comes this odor.
Yeah.
And it was the strong solvent.
Yeah.
And I did some research. Over 99% of what's in that topic click is solvent.
Yeah.
And I've been a functional medicine doctor for 55 years,
Mm-hmm.
and we don't like toxins. And I did the math, and I was detoxifying my women patients at the
Mm-hmm.
same time suggesting that they apply a quart of this stuff per year, 10,
Mm-hmm.
20, 30 years.
Yeah.
And so we did some major work at that point. One of my partners and I, my son,
Mm-hmm.
we talked to a lot of people around the country. We met up with the oil lady. There is such a woman on this
The
earth,
oil
the
lady.
oil lady,
Okay.
Candace, world expert on oils.
Wow. Okay.
And we put together a formula with her that's in
Mm-hmm.
a certified organic oil base.
Lovely.
No solvents, no additives, just a
Mhm.
certified organic oil. You
Lovely.
have to shake the bottle
Yeah.
before each use because it's not a solution, it's a suspension,
Sure.
but you don't have to shake it very much. And we've
Yep.
tested this. Open the beginning, the initial part of the bottle and the dregs of the bottle, they're
Yep.
same. It works really well.
Yeah.
So I really would like to put in a plug for the organic oils
Absolutely.
because
Yeah.
you want the best stuff.
You do.
And the
Yeah.
oil lady really showed
She knows
us
her stuff.
stuff.
Good on the oil
Bless your
lady.
heart.
Yeah.
Yeah,
No, absolutely. You're applying this stuff every day. You want to make sure you're not applying these awful additives and toxins
right.
that the body doesn't need. So yeah, you do have beautiful organic oils. And of course, down here, I say it's the arse end of the world where I am in Australia. I can't get them, of course. But most,
We have two Australian providers that attend Grand Rounds regularly.
oh,
They can get you their names. We haven't got the oils there yet.
no, it's that
We're
might,
working on it
are you? Oh,
big
good.
time.
Oh, good. I didn't know
Yeah.
this.
So
That is
you and
very
I
good
should
to know.
connect, and I'll connect you
Absolutely.
with Julie,
Yeah.
and
Oh no, absolutely.
because we're really trying to get them to Australia.
Yeah, we need more of this. We really are forgotten down here, and we're a little bit slow to catch up to you guys in the States. But most of the ladies and who I work with, and most of the women who are listening to this podcast, they are in the States. So they're going to be wondering how they can find somebody training your method. So do they just go to the Menopause Method website, or how do they find somebody who knows
Go to bright.live, BRITE.live,
brite.live?
or look up my name,
Mm-hmm.
Rosensweet.
Mm-hmm.
David spelled it a little unusual there, Daved.
Yep.
And if you send an email to our staff, we've trained people all over the United States, and in most states we have someone that that we've trained.
Amazing.
That's one way to do it.
Yep. Great. Excellent. Okay. Is there anything else? We've talked about your book. We've talked about how to get in contact with you, find one of your providers. Is there anything else that you wanted to mention?
Well, I think the most important job for every woman is to take this project on. And as you were suggesting earlier, I heard the hint. Take it on early.
Yeah. Oh, yeah.
You'll be fine if you take it on later. We
Yeah.
don't want to discourage anybody.
Yeah.
And here's your job. It's go shopping until you find a healthcare provider
Oh, yeah.
that you trust, you can communicate with, you like, and is taken on the in continuing education, which is significant
Mm-hmm.
to get expert at hormones.
Yeah.
That's your job. Find that person. And there's a lot of ways to do it. I mean, one way is you talk to other women.
Yeah.
Invariably in your circle, someone's on hormones,
Yeah.
and someone who's on hormones really likes who they're working with.
Yeah. Yeah.
And with telemedicine, you don't need to see a physician in person or a nurse practitioner in person at all. You can anywhere in Australia,
Yeah.
just get on the telemedicine with them.
Yeah.
And when in doubt, you can go to a compounding pharmacist. I suggest you go in live. You
Yeah.
don't call them on the phone. They're very busy people.
Yeah.
But if you walk into their pharmacy and they see there's an actual human there, they'll
Mhm.
come out behind their preparation room and talk to you.
Yeah.
And what you say to them is, I know I need hormones. You're filling a prescription from a lot of providers. Who am I best going to be served by?
The great
Who's
tip.
your favorite? Because they know
Mhm.
who's prescribing good
They
stuff.
do.
No, they can tell when people don't know what they're doing.
Yeah. Absolutely. That is a
You can get their
great tip.
personal recommendation as well.
Yeah.
But however you do it, this is the one place I think it's important to focus your attention
Yeah.
is to find that provider that you like
I agree.
and you trust and really knows what they're doing.
Yeah. Absolutely. Yeah, it can be done and it has to be done. And even if it takes a little bit of time, even if it takes 6 months, this is hopefully going to be your provider for life. So it's
Exactly.
important to put the effort in and find that person. Thank you so much. You are a wealth of knowledge, and I always enjoy learning from you. So I really appreciate your time today.
My honor, Tara.
Thank you. I am not a medical professional, and the information provided in this podcast is for informational and entertainment purposes only. I do not have access to your individual medical history or circumstances, so the content discussed here should not be considered as medical advice. Before making any changes to your diet, lifestyle, or considering the use of supplements, please consult with a qualified healthcare professional or your doctor to ensure it's safe and appropriate for your specific situation. Any decisions you make based on the content of this podcast are at your own discretion and risk. Thank you for tuning in.